This is we'll repeat that. Welcome everyone to the Cancer Screening and Prevention and Action webinar series. This is session 2 for HPV vaccination and tobacco cessation. We are recording this session. We had a really nice first session on lung cancer on November 19th. And in February, we will focus on breast cancer genetics. And I am advancing the slides. So here we go. There is continuing education, and if you would like continuing education credit, you will need to put your name in the box as well as your organization name. If there's a group attending, then please add all the people in the chat for the group that's attending. For continuing education credit, you'll have physician, nurse, and social work, and as well as a certificate of attendance. Next slide, please. Next slide, please. Next slide, please. And there we go, our disclosures. The following committee members have reported their disclosures that are on this sheet, as well as the presentation disclosures will be on the individual PowerPoint slides. Our objectives today will describe the synergistic effects of tobacco and HPV and how the effects have on cancer. Sorry about this. We're having a little bit of slide control issues.
That number 37E, 37 yoga.
So identify risk factors and prevention. And I think we have auto control still on, Tracy, is what I think is happening. So to get your continuing ed credit, you'll use 37 yoga as your for your EAD. So you can either take a picture of this here, as well as, or you can enter it on www.eads.com. Next slide, please. This project is funded by the Center for Disease Control and Prevention and Kansas Department of Health and Environment, with additional support from the University of Kansas Medical Center and Masonic Cancer Alliance. I really want to thank those sponsors, as well as our 4 presenters, Dr. Greg Gahn, Dr. Rubina Ratnaparki, Dr. Amanda Applegate, and Ms. Ann Zeich. So thank you all for your willingness to provide this presentation. And here are the topic series that we mentioned earlier. And our agenda for today. And just as a reminder, Kansas Cancer Partnership is a cancer consortium for the state, and we would love to have your participation in this activity to address prevention through survivorship. And so, Dr. Gahn, you may need our assistance with some of the
okay. So that's
sliding.
Okay.
Of course.
But I'm going to put everyone's bios into the chat, because in order to really get through this quickly, I want to make sure that we're really spending time on the presentation. But please read the speaker bios that I'll be entering into the chat now. Thank you, Dr. Gahn, for your presentation.
Thank you so much, Hope. Thank you very much to the Masonic Cancer Alliance, as well as to Hope and to all the other organizers of this meeting, and for this invitation to present. Again, my name is Greg Gahn, and today I'm going to talk to you about the impact of human papillomavirus, and as well to some degree on smoking, regarding the rising incidence of oropharyngeal head and neck cancer, particularly in the Kansas area and around the United States. So let me see if I can get to the next slide. Oops. Okay. Oops, let me re-request that. Okay. Whoops. Here we go. Here are my disclosures, none relevant towards this presentation. So oropharynx head and neck cancer, where is it? Kind of what are the major things that comprise it? So head and neck cancer is a conglomeration of a variety of different sites. You have the oral cavity, which is like the front of the mouth. You have the voice box, we call the larynx. And then you have, and again, in addition to other places, but what I'm going to focus on today is the oropharynx. The oropharynx consists really of three major things. First is your palatine tonsils, which is like the traditional kind of, it was considered the traditional tonsils that kids in the past used to have removed when they were younger. You have the base of tongue. Okay, so this is your tongue. It's this little portion in the back right here, which is another lymphoid organ. And then you have the soft palate, which makes up the arch and that little quote unquote punching bag that we oftentimes see, the uvula in the back of the throat. That is your traditional oropharynx. We are seeing a rise of oropharynx cancers across the world, and particularly in developed first world countries, due to the human papillomavirus. Along with that, with decreasing smoking rates, we see that the rise of HPV negative head and neck cancer is on the downslope. Now, one of the biomarkers that we routinely use when we can't do HPV testing is to look at P16 status. And I'll just briefly kind of discuss kind of where is P16, but is it an immunohistochemical stain that our pathologists use to visualize on a specimen slide whether or not you may have virally mediated head and neck cancer. So briefly and everything, this is a DNA type of virus which, when it infects within the oropharynx, the virus itself goes to the area of the base of the basement membrane where it infects cells. Those cells, once they contract it, have certain proteins that get overexpressed that help to suppress normal brakes and accelerators for cell cycle. In doing so, these cells continue to replicate rather quickly. They develop mutations before they become malignant. Now, what are these two most important things that you may hear about either in the clinic or on websites? HPV can secrete proteins E6 and E7. And these things themselves, E6 helps to inhibit P53, also known as the guardian of the genome, which is important for putting the brakes on a cell, especially when there's a mutation or some kind of error in the DNA, so it can be appropriately fixed. Because you lack P53, the cell keeps cycling. On the opposite end, E7 actually helps to inhibit RB. Again, another break in the machinery. And when you lose RB, you actually have an overabundance of proteins that stimulate the cell to want to go into cell cycle. One of these inhibitory proteins that gets modulated, okay, specifically prevents the shutdown of another protein, P16. And when you have very high levels of E7, one of these HPV mediated proteins, it leads to high levels of P16. Thus, when you have HPV infection, E7 activation, you will then have high P16. High P16 is that alternative surrogate marker that we use again, that our pathologists use to help in diagnosing HPV-mediated oropharynx cancer. So what do we see? Oropharynx cancer, again, used to be a very smoker alcohol-driven type of cancer. Over the past couple decades, we're seeing that shift where lifestyle changes has led to development of a non-smoker, non-alcohol mediated oropharynx cancer. So again, kind of to highlight with some hard data, we see in everything like that in the gray bar here on the left, a decrease in HPV-mediated head and neck cancer. That's the smoker variant, and a rise in HPV variant. Along with that, when you look at other head and neck cancers like oral cavity, larynx, all of these are going down because smoking is decreasing. But oropharynx, which is this line right here, is going up. Now, when we actually look at this, and again, this is looking at rates per 100,000 annual number of cases, you can see that representative rise. Interestingly enough, when you compare this between men and women, while cervical cancer has actually gone down, and this kind of crossed in 2010, oropharynx cancer is going up, with the greatest rise being seen in men. Again, looking at cases per 100,000 and annual number of cases. Now, kind of hitting home again, again, when you look at this from the American Cancer Society and kind of focusing in on oropharynx cancers, you can see that in men, particularly, there's more than a doubling of this over the past 2 decades. In contrast to this, women, there is still a rise, but just not quite as steep. The average age is around 50 to 60. And when you look at specifically, and again, I apologize, this is small, but the main thing to highlight, men on the left, women on the right, both see an increase in Missouri and Kansas, Missouri in yellow, Kansas in red. The greatest increase again is being seen in men. There is still some increase, though albeit smaller, in women. Now, again, kind of zeroing in, you can see overall the incidence of HPV-mediated oropharynx cancer in Kansas specifically is going up and trending and going up in over time. And really, we're not seeing a real difference between rural and urban environments. While the proportions for urban are twice that of rural, it is still fairly constant in terms of kind of who is getting HPV-mediated head and neck cancers. Okay. Now, what are the classic risk factors? As I've mentioned, there are multiple risk factors: alcohol, smoking, which is one of the predominant things, and HPV. And so while you do not need one to actually predicate contraction of oropharynx cancer for one or the other, both are considered independent risk factors. That said, we do see trends, and these trends and everything that exist where if you tend to be more of a heavy smoker, greater than 20 pack year, you're a heavy drinker, or for that matter, you are both, the likelihood of you or the odds of you actually being HPV mediated head and neck cancer, as shown here, is less. In contrast to those individuals, oops, pardon me. Oh, in contrast, if you tend to be more of a heavy smoker, heavy drinker, greater than 20 pack years or greater than 15 drinks per year, you tend to be less likely to be HPV mediated. Now, what are the challenges with HPV-associated oropharynx cancer? Well, first off, we don't have any precursor lesions that have been identified. And this is unlike cervical cancer, which you can easily biopsy early on and capture at an earlier stage. In addition to this, we lack an established assay or screening test. So unlike in cervical cancer, we have a very classic and very well-tested test, such as the pap smear. No such test exists for head and neck cancer. And I'm like, we have some things in early development, but they're very early. In addition, we have a long latency period. From the time of virus exposure to the time of a person actually developing cancer, this could be anywhere from 20 to 30 years from that initial exposure. So, in terms of its presentation, oropharynx cancer itself can present with a painless neck mass, difficulty with swallowing, particularly if it's in the base of tongue, persistent sore throat, again from a tongue or from a tonsil cancer. You can get this referred ear pain that kind of comes and goes, as well as weight loss, just because of a desire not to want to eat because of a mass in your throat. Okay. So how are these types of cancers managed, of the oropharynx? Well, for very early stage cancers, you can use either surgery or radiotherapy as a curative approach. The goal is one treatment and try and minimize side effects as much as possible, which is why we try to stick to one modality. In much more locally advanced cancers, where you have the cancer that's not only in the primary site, but is now spread to the lymph nodes, okay? Those patients are going to require either surgery with adjuvant radiation treatment and or chemotherapy based on risk factors, or the alternative, you want an organ-sparing approach to try and minimize the risk of surgical complications. Or, again, these patients are not good surgical candidates, you can go with a definitive chemoradiotherapy approach. Again, another curative approach for this type of cancer. The outcomes in general for this class of patients, those who are HPV mediated with a less than 10 pack year smoking history, they have the best likelihood of overall survival at 3 and 5 years, 93%, quite high, much better than many cancers that we will encounter. In contrast, if you're a smoker mediated, HPV negative, okay, your overall survival at 3 years is around 46%. And if you actually take it out to as far as 5 years, that can drop as low as 35 to 36%. Now, there is that group, as I said, they are not mutually exclusive of one another. You can be HPV mediated and still be a very heavy smoker. You're kind of in this intermediate risk group, and your survival at 3 years is around 71%, 65 perhaps at 5. So again, this population down here, we need to find ways to escalate therapy. This population up here, we are trying to find ways to de-escalate therapy. And the reason for that is because of the potential late side effects. I'm going to feature some of the ones that we see routinely in chemoradiotherapy, but obviously there are surgical complications and side effects that mirror some of these. Early on, while you're undergoing treatment, many of these side effects are manageable and can be overcome and will eventually resolve. But it's the late side effects that we're most worried about. In the acute setting, problems with pain or discomfort with swallowing, voice changes, weight loss, skin irritation, tiredness, as well as taste change. In the late ones, and again, these are things that we're most worried about: swallowing dysfunction, aspiration pneumonia, problems with your voice box, fibrosis and lymphedema are big things, more persistent dry mouth. And all of these things at the end of the day really impact quality of life. So the big take home points that I want to highlight: HPV-associated head and neck cancer of the oropharynx is on the rise. The incidence of smoker-mediated is going down nationally, HPV-mediated is going up, and these trends are very similar in Kansas as it is nationally. HPV-associated oropharynx cancer confers a much better prognosis and survival. Smoking reduces this survival benefit substantially. HPV-16 is the primary driver of oropharynx cancer. A vaccine exists to immunize against HPV. This was started in 2006, only available to girls, but now it's covered for both boys and girls. So I would strongly encourage that all individuals should follow CDC-related guidelines, and boys and girls and young adults should be vaccinated, because the value of this vaccine may not be seen for another 20, 30 years, which is why we may not be seeing anything at the moment, but we will in the upcoming decade. And so I think this is something that has a way of potentially eliminating a type of cancer and is an important step forward. With that, I'll be happy to turn this over to the next speaker.
Thank you, Dr. Gahn. And it's my real pleasure to introduce Dr. Ratnaparkhi. And as we're starting, she'll click on to the 3 dots by Tracy's name and ask control for the slides, or you may ask us to advance them for you. I have placed everyone's bios in the chat, so you can read about Dr. Gahn, Dr. Ratnaparkhi, and Dr. Applegate, as well as Ann Zyke as we move forward. So handing it over to you, Dr. Ratnaparkhi.
All right, everyone, thanks so much for having me. So my goal for this talk is to build on the excellent explanation of how the HPV virus works that we received from Dr. Gahn and talk about that more specifically in terms of how it relates to cervical cancer. Next slide. So I wanted to start off by giving a picture of the local context in the state of Kansas. So overall, we can see that the incidence of cervical cancer has remained stable in the past 10 to 15 years from 2011 to 2021. Similarly, there have been no significant differences in the incidence based on different age groups or other socio-demographic statuses. So this suggests that the HPV vaccine is effective in preventing and maintaining disease control, given that we have the stable incidence, and sort of the continuing number of new cases that we see is primarily among unvaccinated or immunosuppressed patients, which is a point that I like to highlight because oftentimes there can be some confusion wondering if, a persistent incidence of cervical cancer relates at all to the efficacy of the vaccine. In this case, we know that it does not. Next slide. In a same vein, we can see that mortality rates for cervical cancer in the state of Kansas have overall remained similar. So if we talk about that incidence being between sort of 8 and 10 per 100,000, overall the mortality rate is about a fifth of that, so anywhere between 1.5 to 3 per 100,000. However, in the mortality rates for cervical cancer is where we begin to see the impact of ongoing disparities for vulnerable patient populations. So we note that for our Black patients, mortality rates are overall 2 times higher, with 5.4 deaths per 100,000, highlighting the ongoing burden of structural racism in our healthcare system. Next slide. So there are multiple risk factors for cervical cancer. First and foremost is human papillomavirus, as we discussed. Most specifically, there's a subset of high-risk strains that are most associated with cancer. So HPV 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59. You hopefully will not be tested on them, as I was. Additionally, sort of other risk factors we think of as being facultative or sort of having a causative or contributive effect in carcinogenesis is sexual activity without barrier contraception use, tobacco smoking, HIV, and immunocompromised state, which together all really contribute to the likelihood of patients getting an HPV infection and being unable to clear that virus. You'll see in the literature reported some additional associative risk factors that have associations with cervical cancer, but it's important to note that none of these directly cause the disease. So things like oral contraceptive use, high parity, as well as obesity, which we thought to be primarily related to the lack of adequate cervical and pelvic exams for patients with obesity. This distinction is important when we're counseling patients to avoid stigma associated with these factors. Next slide. So when we talk about cervical cancer prevention, there are sort of three main types of prevention that we talk about. So primary prevention aims to prevent the disease, in this case, HPV infection, before it occurs. This primarily works by means of HPV vaccination, smoking prevention and counseling, sexual health education, including barrier contraception use, as well as circumcision. We then transition to secondary prevention, which becomes more relevant in the adult years, which seeks to reduce the impact of HPV infection by treating cervical dysplasia or precancers as early as possible to slow or halt its progression to cancer. This includes our cervical cancer screening pathways, incorporating HPV testing, and incorporating expedited treatment with Leaper cones as needed, as well as considering use of cryotherapy or other adjunctive therapies in low resource areas without access to definitive treatments. Finally, our last stage is tertiary prevention, which we generally hope to intervene before we get here. And this involves treatment and management of the impact of a diagnosed cancer, which can include a combination of one or more of surgery, radiation, and chemotherapy. Next slide. Won't spend a ton of time on this slide, but just important to think about as well that when we think about each of those three levels of prevention, so primary, secondary, tertiary prevention, that those all have corresponding infrastructure needs within our healthcare system. So including clinic resources, human effort, awareness and education campaigns, as well as clinic equipment and infrastructure that are needed to carry out these vital activities. And as we think about, what are our needs in terms of awareness and education campaigns in the state and local area, where are our needs for public health outreach, increasing access to care. These are sort of the main, institutional or structural factors that we think about. Next slide. So in 2019, ASCCP, which is the main national society that sets our guidelines for screening and management of cervical cancer, updated these screening guidelines. What this represented as a change from the prior guidelines was a more individualized management of cervical cancer screening results. So this takes a combination of the patient's current PAP test or HPV test results, in addition to prior HPV or PAP test results, to come up with a patient's current and 5-year risk of SIN3, which is high-grade cervical precancer. Based on that risk threshold, you can see in that diagram on the right, the different interventions that are recommended. So either, diagnostic testing with the colposcopy, treatment with a very high risk, or closer interval screening when there's overall a lower risk of CIN3. Overall, these recommendations can be very difficult to keep track of because they incorporate multiple management algorithm, which can be difficult to remember, as well as difficult to explain to patients. On the left-hand side, you'll see that ASCCP has developed a mobile application. So this can be used on phones, so including Apple and Android phones. There's also a web-based application at the link that's there, which can help all providers and nurses who are counseling patients to provide guidance on managing test results, counseling for patients, generally available for about $20. And I literally, every time I am managing any type of cervical cancer screening or biopsy test result, I refer to this app every single time. So it's a handy and very easy to use resource. Next slide. Similarly, with this 2019 revision of guidelines has created a lot of confusion, both among providers and patients. Before, patients and providers were used to always having sort of a set 3-year or 5-year interval for screening and sort of the same follow-up managements, where we know now that different combinations of tests and test results can lead to changes in management. You can see here, there are examples of sort of new social media, print and web-based campaigns that are really meant to help educate our patients and sort of explain what the different testing options they have are, as you can see on the right, and sort of the rationale for why the recommendations and screening intervals change by age and sort of what factors there are on the left. We have links to both of those at the bottom of the slide. These are important resources even for community health workers and clinicians who are intimately familiar with the new guidelines, as we know that studies show that providers who are quizzed on sort of the next step or result in management and control studies nevertheless guess wrong without use of the app or sort of these standardized tools. And additionally, patients also have lesser trust of providers and understanding of screening procedures without clear and comprehensive counseling and education. And these visual resources can really be helpful in that goal. Next slide. It's also important when we're talking about our counseling and education for our patients about these evolving cervical cancer prevention guidelines that we talk about them in terms of sociocultural determinants and psychosocial constructs that matter to them in the context of their everyday life. Cervical screening is one of many health maintenance behaviors that patients must balance and navigate relative to personal, professional, and role responsibilities. One qualitative study, which this slide represents, interviewed a cohort of Black patients in the South and identified 5 key themes of beliefs that impacted their willingness to engage with cervical cancer prevention behaviors. These included issues around screening, issues around social support system, which were most prevalent, and then additionally statements related to knowledge, ease of prevention, and fatalism. The most agreed upon statements within the cohort you can see under those headers here. And again, this is only a sample of about 100 or so beliefs that they tested. And so it's important to know and be familiar with these examples. This is not representative of all patients. This was a very specific patient cohort, but it is important for us to know what to ask and what to be curious about as we support our patients in this journey. Next slide. And then one resource that is important for us to highlight in the state of Kansas is that free cervical cancer screening and diagnostic testing is available for low-income uninsured patients through the Kansas Early Detection Works program. This program is funded by the CDC, or Centers for Disease Control, and is run by our Kansas Department of Health. So there are links at the bottom to learn how to connect patients with these resources, how to find EDW providers or to become an EDW provider, and both enrollment as well as provider services are available in English and Spanish as listed here. Next slide. For this last portion of the talk, I'm going to switch gears slightly and talk about an emerging area related to anogenital cancers. So similar to the way that HPV can cause cervical cancer, HPV is also associated and thought to cause anal cancers. And as you can see on the left, the incidence and mortality of anal cancers have increased quite dramatically in the past 15 years. Most commonly, this is seen among patients living with HIV. That being said, among patients that are newly diagnosed with anal cancer in these past 10 years, the majority of new anal cancer diagnoses were among patients who are female, white, and over the age of 50, which implies that there are additional risk factors or causative factors contributing to the development of anal cancer in this population besides HIV alone. And so another way that we are seeing the impact of HPV infections relating to cancer diagnoses for our patients. Next slide. Again, this was recently published in 2013. This was the ANCHOR study, which was led and conducted out of UCSF in California. So this demonstrated that screening with an anal pap test, which is sort of similar to the cervical version, but actually does use a different testing kit and a slightly different procedure to perform that exam, as well as secondary prevention, so treating precancer during high-resolution anoscopy, is effective in preventing anal cancer. So again, that same data that we see in cervical cancer that screening and treatment of precancers is effective, we have now seen that that has been proven in anal cancers as well. Guidelines specific to the care of our patients living with HIV recommend screening for our HIV or high-risk patients. So asymptomatic patients with HIV at least once at age greater than 45 or at age greater than 35 for men who have sex with men and transgender women. So you can see those guidelines at the link that's below. And this will be an important area to keep an eye on for research and clinical guidelines as they are evolving, as I imagine the populations that are recommended to be screened will expand over time. Next slide. So we covered a lot of information in this. You know, the cervical cancer screening and management guidelines are an hour-long talk in and of itself. So I have my contact info here, and thank you for your attention. And I'm certainly happy to follow up with anyone offline if there are more questions or areas you'd like me to dive into greater detail to at a later time. Thank you so much.
Thank you, Dr. Ratnaparky. Really appreciate it. And she ran from surgery to give this presentation. Both Dr. Ghana and Dr. Ratnaparky are surgeons, and so I really appreciate the time that you spend engaging with the community as well. And with that, it's my pleasure to bring on the next speaker. We'll hold the questions to the end, but please start putting your questions into the chat. Dr. Applegate is our next presenter, and she will bring us home with talking about immunization against HPV associated cancers. So next slide, please.
Thank you so much. So, you know, I'm coming here from a couple of different roles, and I'm excited to be a part of both of them. To Dr. Ratnaparky's point from earlier is the best thing we can do is prevent something from ever happening in the first place. And so that's what I'm here to talk about, is the idea of HPV vaccination. If you go to the next slide, please. I think, you know, one of the things I can't explain how lucky we are is we're lucky enough to have a vaccination available to help prevent HPV. To date, we have one vaccination product available, which is Gardasil 9. The 9 signifies that it covers 9 different serotypes of HPV, including the ones that most commonly cause cervical cancer. You know, as a quick overview down below here, we show that the recommendations for the use have changed and expanded since the first HPV vaccination product was introduced in 2006, only containing some of the early products only had 2 to 4 of the different serotypes. So having 9 serotypes in this one product is pretty phenomenal. You know, it was first introduced in 2006, and the recommendation started out with a 3-dose series in just female, so young girls with catch-ups through age 26. And over the years has expanded as the data behind it has grown and shown how effective of a product this can be. So if you'll hop to the next slide. So there are actually right now, these are the current recommendations from CDC's ACIP committee. So CDC recommends these specific ways to utilize the vaccination. So the current recommendations are divided into essentially 3 separate categories. The first and most important is going to be routine vaccination, but there's also catch-up and shared clinical decision-making. So the strongest recommendation is for routine vaccination in all children, usually at the 11 to 12-year-old well-child visit. And that was designed in part to coincide with 2 other vaccinations that were due at that time, a meningococcal vaccination and tetanus, diphtheria, and pertussis vaccine. And the thought behind that was in large part, well, hey, we're already giving some other vaccines, so this is a flag to say, let's give, one more vaccine at that time. However, they found really at this point to increase acceptance of the vaccination, many pediatricians are moving towards starting at the younger age recommendation. So it's always been allowed to start at age 9. And many pediatricians are moving that way, in part because that helps protect the children long before they initiate any sort of sexual activity, as well as it just decreases the number of vaccinations recommended in that single visit. So again, that idea of getting Tdap and meningococcal at the same time may help remind the clinician. But if you ask a child, do you want 1 shot today or do you want 3 shots? The answer is always going to be 0. But the idea is, potentially just doing 1 shot at a time can actually be more beneficial to getting that in and getting it done. So starting that at age 9 is becoming more and more common because that can improve the acceptance rates by children and family. So catch up is for those that didn't get that routine vaccination at age 9, to 12 for any particular reason. Get them caught up. Just no question, get them caught up. That is the recommendation that's standard there. And then also past age 26, so age 27 to 45 is the assumption at that point is the person has initiated sexual activity, and so may have already been exposed to HPV. However, if there are people that are at higher risk, the clinician and the person can work together to say, is this going to be a benefit to me? Am I going to benefit from this vaccine? And can make that decision to vaccinate using shared clinical decision making. And all of these recommendations are covered by insurance. So if a person is lucky enough to have commercial insurance, those should be covered because they are CDC and ACIP recommended. So what that series actually looks like, if you'll go to the next slide, is that, a nod to starting that series early when it's supposed to be routine is that if you start that before a child's 15th birthday, only 2 shots are needed to complete that series. One at the start and one 6 to 12 months later. If that series is started after the 15th birthday, for whatever reason, there are 3 shots that are necessary at that time. One at the start, one at 1 to 2 months, and one at 6 months out. And then also 3 shots are always recommended if a child is immunocompromised to make sure that they're fully protected since their body does not respond to vaccines as well as somebody that has a fully functioning immune system. So getting that started early, fewer doses involved. And now that I've said all of that, if you'll go to the next slide, please, there may be some changes to this vaccination recommendations coming soon. So studies that led to that 2-dose schedule. So again, if you reminder back to that timeline, is it started out as always a 3-dose schedule. That 2-dose schedule became a possibility within the past, I think 6 or 7 years. So studies that led to that 2-dose schedule that was recommended sparked the interest in the possibility of a single-dose schedule. And initial data from some studies being done across the world have actually led the World Health Organization to allowing for a single dose as an off-label option, with the recommendation that the simpler and cheaper we can keep vaccine recommendations, the more people that we are able to effectively protect both here and abroad. So there are studies ongoing right now in multiple countries looking at both the antibody response as well as just the more important part of that is the clinical responses. Are we preventing cancer? Are we preventing HPV infections? And there are studies completed right now in Costa Rica, India, Kenya, and Tanzania, but studies ongoing elsewhere too. But they've all demonstrated similar responses between a single dose and multiple doses. They've shown it to be very effective compared to control groups as well too. So if you can get the same effects or same or very similar effects out of 1 dose instead of 2 or 3, the fewer doses, the better, I think, for everybody. So Merck has actually announced plans to do a randomized double-blind multi-year clinical trial of a single dose option in the United States. So this is something that may be coming soon as well, if it doesn't make a change soon. 58 countries actually recommend a single dose schedule, including some of those near us, Australia, Canada, and Mexico. So all of that, we might see recommendations to decrease that number of shots overall, which again, if you ask anybody if they want fewer shots, the answer is always yes. So the other factor being considered for a recommendation change is actually the age at which routine vaccination is initiated. So again, right now it says 11 to 12 with the option of 9, and that's always been an option. But with the benefits of starting sooner, showing better completion rates, as well as still good acceptability by both parents and providers, there's some real strong consideration to go ahead and change that language to make it a recommendation to start at 9 years. So we can just go ahead and get that series out of the way before that meningococcal and Tdap are recommended at that 11 to 12-year-old age visit. So the people that work on these decisions are CDC's ACIP committee. So that vaccination work group has been working for more than a year at this point to review all of the available data that's out there. So studies done all over the world. And they're actually planning for a vote in late February, so about a month from now, on both the number of doses in the series as well as wording around the age for routine vaccination. So all of that we just presented definitely still applies, but no, it may change soon. So stay tuned because that could be some exciting changes that could really protect more people globally. So Next slide, please. I think it's important to talk honestly about the idea that no medical intervention comes without risk. If you take Tylenol, it has risks. So it's really important for providers to really honestly discuss safety with both parents and patients. I really always think too, knowing what to expect can really help prevent concern if it happens, starting in the middle of the night, 24 hours later or something like that. Because if you're expecting, oh, hey, my provider said my arm might swell up, you're not freaking out and Googling in the middle of the night saying like, oh my God, was this supposed to happen? I think the most important thing to point out about this one is all shots hurt. It's part of procedural pain overall, but this one is especially painful. Almost everybody reports pain after the injection. And for those of you older adults that may have had the shingles vaccine, that's actually down in the 60s. And that's another one that 60 percentile is, that's another one we say this one's painful. This one's going to hurt. So especially, this one it's just counseling and just making sure that providers are really taking steps to help decrease procedural pain. So one of the things I really recommend there is using techniques found in the MEG Foundation's procedural pain resources. So especially targeting that towards the age group that you're recommending, or you're administering that vaccination in. So whether it's a preteen, in that 9 to 12-year-old visit, an adolescent, or an adult, there's a lot of different things that you can do to help make a vaccination more comfortable. Deep breaths and distraction can really go a long way into making sure that, the person doesn't experience undue pain as a result of this. So one thing that we hear fairly commonly after HPV vaccination, and this shared as a concern, is the idea of fainting after the vaccination. And there's really nothing to show that is way more common after this. It's just very common in adolescents. Is they're young enough to understand that they're going to have to get this. They understand that there's a shot going, and they really work themselves up ahead of time. So fainting is very common in preteens and teens alike. And so some specific techniques for that are going to be, if you can help actually clenching stomach muscles specifically can help pull some of the pain and distraction away from that arm and help actually maintain blood pressure after a vaccination in adolescents specifically. So that's one thing, is just making sure that the person getting vaccinated is comfortable and knows that it's probably going to hurt, but there's things that we can do to help control that. So in addition to safety, if you'll hop to the next slide, this is a very effective vaccine. We can talk antibody response overall, but the more important thing really is that clinical response. And we've got some great data showing that HPV vaccinations decrease both HPV infection. So the top dose here is, these HPV types prevented by Gardasil, because obviously we can't look at all of them. We're only looking at those 9 specific serotypes. It's decreased 88% among teens and 81% among those slightly older women. So I cannot, it's just an amazing response that you see that happening overall, is that infection is not happening in the first place. And that rate of infection has dropped over 80%. So that's just a stunning change between what we had, 20 years ago when these vaccines were first introduced to now. In that time, we've also seen cervical precancer rates decrease, but we also see that these have a really long duration of action. So we're going to see, multiple studies that show we give them at a young age to help prevent, before that infection happens in the first place is when it's going to be most effective, but it keeps preventing for a long time after that as well too. So I think that's really important to point out. So next slide, please. So we can actually see that Kansas has made significant progress getting kids up to date over the last decade. Kansas actually used to be one of the last 2 states in the nation in HPV vaccination rates. We were really terrible at it. And that actually spurred the creation of Immunize Kansas Kids, which was the precursor to the Immunize Kansas Coalition that I'm currently the outgoing chair of. Interestingly, we see these as a little bit different than what you might think. So nationally, the factors leading to low HPV vaccination rates are lack of insurance, those who live outside of metropolitan areas, so children in rural areas especially, and white children have a much lower vaccination rate than those of other races or ethnicities. Children on Medicaid, Hispanic children, and those in large cities are the children most likely to be vaccinated, so have a full vaccination series from HPV too. So next slide, please. So as providers, I see there's a lot of providers that are here in the chat today, whether you're nurse, physician, community health worker, whatever it is that's recommending these vaccines. There's a couple of different ways to do this. And we know, from across all vaccinations that strong provider recommendations are really critical to vaccine acceptance from a parent or vaccinee, and then also vaccine confidence. So being confident in the idea that this vaccination is going to, prevent or decrease the disease that we're trying to work on here. So I think the biggest thing is provider recommendations are key. You miss 100% of the shots that you don't take. So if you're not recommending the vaccine, there's probably unlikely the child is going to get that vaccine. So one of the things that you can do to really help improve acceptance of that vaccine is just really start by assuming the parent or patient is going to accept that vaccine. So say, hey, Sarah's due for 3 vaccinations today, so we're going to go ahead and get those ready. And the way I always explain that is don't ask if you want a vaccine. I am a board member of the Immunize Kansas Coalition. If you ask me if I want a flu shot, the answer's always going to be no. Nobody wants a vaccine. Nobody wants a shot that day, even if they know it's going to help them. But will they get it if it's absolutely. So, the next step is most people are just going to say, yep, let's get that child protected. But if they do have questions, we need to make sure that as providers, we are taking the time and we are taking, giving that patient the respect that they are due by taking those concerns seriously and addressing them. So, you can use at that point motivational interviewing techniques to really help keep that conversation open and respectful, and understand that it's probably going to take multiple visits to build that trust. So, I think a lot of us in the Midwest look to our famous soccer coach, famous fictional soccer coach, Ted Lasso. But I think his, statement of being curious and not judgmental is a really great way. Asking those questions, answering honestly, and making sure that we're doing our best to get vaccinations in arms, even if it takes a couple of visits too. So next slide, please. There's a couple of different ways to do this. Strong provider recommendations are important, but also hearing fears addressed by somebody from their community may actually help parents overcome misconceptions and gain confidence in a vaccination too. So if you have a community health worker in your area available to you, this can be a really great way to build trust in a community and ensure higher vaccination rates too. I am biased, admittedly, but pharmacies can be a great place for catching children and adults that have not yet been vaccinated. So maybe the child didn't have a pediatrician as they were growing up, and maybe they're new to the area, et cetera. Or the provider that they saw for adolescent visits, maybe had a parent fearful of vaccinations that they didn't get any. Whatever the reason, pharmacies are a good way to address that catch-up demographic. So, we all want kids to keep going in for those well-child visits, but addressing those, in ages 12 years and older that Kansas pharmacies can administer vaccines to can be important. And I want to point out too, access to vaccinations without insurance. So this is one that is a pretty expensive vaccine compared to some of the others. So vaccines for children is a great option. So our country is lucky enough right now to have access to no-cost vaccinations for all children up through age 18 years and 364 days. So right up to the day before that 19th birthday, if a child is uninsured or underinsured, they can access vaccines for children at a VFC provider site. And KDHE can assist in finding those. There is a list on the KDHE immunization website, and I will drop that in the chat as soon as I'm done talking here. And then also for adults, so that 19 years and on, patient assistance programs are an important way that the insurance or that the manufacturer of the vaccine helps cover that for those that can't otherwise afford vaccinations. It wouldn't be me talking about vaccinations, if you'll go to the next slide, if I didn't talk about our Immunize Kansas Coalition's Vaccine Fears Overturned by Facts. And fears are scariest when they come with a grain of truth, and nobody knows that better than a mom who used to be anti-vaccine. And so this resource booklet was written by 2 moms who used to be very anti-vaccine, very scared of vaccinations overall. And they took this and they have utilized science, facts, information to really climb out and found themselves on the other side of that as advocating for vaccines. So one of the myths that they they talk about here is the idea that, does the HPV vaccine cause infertility? And the answer is no. But there's a little grain of truth that comes along with it. And so this is one where, the whole booklet addresses a lot of different vaccine myths like that from that perspective of the moms, to talk to other people worried about vaccinations and the misconceptions surrounding them. So great resource. You can find this on the Immunize Kansas Coalition website, for a lot of different myths. And one of the things I always say is, I was too old. I was past the age of recommendation. I was well into the catch-up age because I was in college when the vaccinations came out. And my mom got me to a pediatrician because they were the ones that carried the vaccines at that point, and she said, you get this vaccine, because she was already a cancer survivor at that point. And she knew that, if there was anything that she could do to prevent her child from getting cancer and she didn't do it, she would never forgive herself. And so I think that that's an important way, is, coming at that from the point of you can help prevent a child from developing cancer. And I think that's very important. So I want to end on the last slide here, for a couple of opportunities for tobacco cessation as well too. So strong provider recommendations are important. And so this is one where Kansas Tobacco Quit Line can really help, because we understand that, providers can have a hard time, having time and opportunity for tobacco cessation conversations. So Kansans can get help at the Kansas Tobacco Quit Line, that can help talk people through that. And 1-800-QUIT-NOW or ksquit.org. There are text-based resources. There's a lot of different ways to access that. So I think it's a really great place to start. And then I also want to point out is, because this catchment includes some people on the Missouri side, people can actually go to pharmacies for the evaluation and management of tobacco cessation products. So whether it's getting a prescription for a nicotine replacement inhaler, or some counseling necessary to get through the, gum and lozenge effectively, can be really important in a way to access that too. So I see Hope is wonderful and has put those links in the chat already. So thank you so much for providing those links. You are amazing. And I'm going to turn it over, I think, to Hope, but to somebody that I have been blessed to work with before, and I'm very excited to hear from again. So
Thank you, Dr. Applegate. That was great information. And I know you'll be hosting the our time when we have office hours to really think about how to implement HPV vaccination and practices. So with that, it's my pleasure to introduce you all to Ann Zeich, who will be sharing her personal experiences. And then at the end, we'll have time for additional questions, but please go ahead and type any questions you all may have, just in case we run out of time, so that we can send them to the speakers and we'll respond to everyone with the answers. Go ahead, Ann.
Thank you very much, Hope. And just before I begin, I am going to drop a link in the chat. Wednesday, I will be actually leaving Kansas for Washington, D.C., where Survivor is going to be hosting the Cervical Cancer Summit. It's an incredibly worthwhile experience for providers, patients, survivors, caregivers alike. So I invite you to attend. We do have a virtual option if you do have interest in this. We would love to see you in attendance. So again, thank you very much for allowing me to present today. I just want to first have you take a think back. Imagine waking up from anesthesia. You're feeling groggy and disoriented, and you hear the words, "You have cancer." That was my reality in August of 2016, and it's a moment that forever changed my life. So my name is Ann Zeich, and I'm an 8-year cervical cancer survivor, and I'm very passionate to advocate for HPV prevention. In February 2016, I started experiencing some abnormal bleeding. I initially thought it was just a postpartum period because I had had twins in November of 2015. However, by May, the bleeding had not stopped, so I made an appointment with my OBGYN, and she ordered an ultrasound to rule out conditions like ectopic pregnancy or endometriosis. She did not perform any other exam, and the sonogram did not show any concern for ectopic pregnancy or endometriosis or any other condition. So the months went by and my symptoms worsened. The bleeding became heavier, pain became so intense that there were days that I had to miss work. And I did repeatedly call my OBGYN and her nursing staff. Unfortunately, I was made to feel very dismissed by them. They prescribed medication to stop the bleeding. That medication only worked for about 3 days and then later offered pain medication as their solution. Finally, in August of 2016, my doctor called and said that the only remaining option was an ablation. She scheduled that for August 12th. I felt unheard. I felt frustrated, but I went ahead and went through with that procedure, not knowing that it would lead to a life-altering diagnosis. That day, the day of the procedure, I woke from anesthesia and I overheard the nurses saying that the procedure couldn't be done. And that confused me. So I asked what happened, and my doctor approached my hospital bed and she told me that I had cancer. So I was diagnosed with cancer, cervical cancer, at 34 years old. Just one day before my daughter Clara turned 3, and my twins were about 9 months old. So the following week, I had a CT scan, and that revealed a tumor that measured approximately 4 centimeters. My doctor then referred me to the University of Kansas Cancer Center. And by the time I met with my gynecologic oncologist and had an exam under anesthesia, they found that the tumor had already grown to 6 centimeters. My treatment for this cancer, I'll note that I was staged 1B2 at that time. My treatment consisted of 6 cycles of chemotherapy, 30 rounds of external radiation, and 5 rounds of internal brachytherapy. So those months of waiting and feeling dismissed left me with far more than just a diagnosis of cervical cancer. They left me determined to advocate for myself and others. I do not want anyone to ever feel unheard in their fight for answers, their fight for healthcare. So, as has already been discussed today, HPV causes most cervical cancers. And once I understood this connection, I knew that prevention is key, not just for my health, but for the future of others, all others. Preventing HPV-related cancers can ultimately eliminate diseases like cervical cancer. And in fact, countries like Australia are on track to eliminate cervical cancer entirely by 2028 through widespread vaccination efforts. In Scotland, there have been, as of 2024, no cases of cervical cancer have been detected in women who have previously received that HPV vaccine. And in the US, the state of Alabama has announced Operation Wipeout, a statewide initiative aimed at eliminating cervical cancer. And this gives me a lot of hope. This motivates me even more to advocate for the HPV vaccine and for cancer prevention. So all of that to be said, I've brought this message home to my own family. My oldest daughter, Clara, is now 11. She received her HPV vaccination at age 9. My twins are now 9 years old, and they are scheduled for their wild child checkups next month. And I will be having them begin their series of HPV vaccinations at that visit. And I am choosing to vaccinate my children at age 9 for a few important reasons. One, research shows that younger children produce a stronger immune response to the vaccine. 2, vaccinating them now means that they will need fewer shots overall. And 3, and most importantly, it ensures that they will be immunized before any potential exposure to HPV. So you may be wondering, how do I talk to my kids about it? Well, I keep it really simple. I just tell them mommy had cancer that could have been prevented. And because I know it will help keep you healthy, I want you to get the HPV vaccine. As a mother, this is one of the most important things that I can do. I can protect their health and prevent them from facing the same kind of battle that I went through. I want to give them a future free of the fear and uncertainty that came with my diagnosis. Since my diagnosis, I've dedicated myself to raising awareness and advocating for HPV prevention. In 2022, I attended Survivor School and St. Jude's HPV-related cancer school. I learned valuable tools and information to fight for cervical cancer prevention, HPV prevention, and to become a patient advocate. Now I am a survivor ambassador, and I continue to share my story, mentor others, and fight for better education and prevention. And I'm also very excited because in February, I will begin to be a part of the HPV Vaccination Roundtable Emerging Leaders Fellowship, where I will have the opportunity to help shape the future of HPV vaccination and cancer prevention efforts nationwide. So in addition to this work, I also advocate for cancer prevention through my role as Kansas ACS CAN Vice State Lead Ambassador. That's a mouthful. I work to mobilize volunteers and support policies that protect public health. So through these roles, I hope to make a lasting impact and ensure that more people, especially children, are protected from the cancers that I've fought so hard against. I encourage all parents to talk to their doctors about the HPV vaccine for their children. Vaccination is a powerful tool that can prevent cancers, and as parents, it's our responsibility to protect our children's health. By vaccinating. Thank you.
Thank you, Anne. We just really appreciate getting a personal story too. I think that you've heard all the data, you've heard some of the information about vaccination. Most of you are healthcare providers, but really seeing the impact that your work has on an individual is important. So thank you to Anne and Amanda and Greg and Rubina for all of your presentations. We could not have been better. This has been taped, so it'll be available for you and others. I will remind you that there's office hours coming up in 2 weeks, and I put that in the chat, so you can just go ahead and sign up for office hours. I've given you plenty of reminders about your CEUs. We can stay on for a minute or two, I think, if there's a burning question, but otherwise just put in the chat. So is there any burning questions before we close for today? All right. Well, you all did an amazing job. A few people had to jump off right before, but we had close to 60 people for pretty much the whole presentation, and it was filled with information. So thank you. Thank you to the attendees. Thank you to KDHE and the planning committee, the MCA staff. None of this is possible without all of you. So we appreciate your time today and see you in 2 weeks. Bye.